The discussion will be trauma and pregnancy. These are the main teaching points of this discussion. Number one, priority must be given to the mother. Save the mother, save the baby. Pregnant physiology is unique and should be appreciated. Obstetrical consultation should be obtained promptly. Trauma remains the highest cause of maternal death. 6 to 7 of all pregnancies are involved in some sort of trauma. In the UCSD experience, we've noticed a significant increase in our trauma population that are pregnant. You can see from 2001 to 2005, there's been a significant increase compared to the previous years. What the reason for this is unclear. Yet nevertheless, the importance that one needs to understand pregnant physiology and trauma is clear. The etiology is very similar to other populations. MVAs comprise over 60% in our population, falls, blunt assault, and penetrating assault thereafter. In the National Trauma Database, according to a study by Akasi, you can see that motor vehicle accidents comprise 70% of all trauma patients. Subsequent to that is interpersonal violence, falls, and other forms of injury. The female anatomy in pregnancy is a little unique. Notice the importance of the gestational age and where the uterus lies. In doing so, the uterus pushes intestinal contents cephalad with increasing gestational age. This becomes in some ways pseudoprotective, especially to abdominal viscera. Uterine and pelvic vessels are engorged, and the retroperitoneum, specifically the vessels coming off the hypogastrics, are large and can bleed intensely. The compression of the inferior vena cava is important. If a pregnant patient is supine, notice how the fetus and the gravid uterus pushes on the actual IVC in a supine position. However, when the patient is lateral, the uterus is displaced and you have good flow into the IVC. You notice in a study by Guer et al., you notice that in a patient who's supine, compression of the IVC as measured by cross-sectional area is approximately 35%. However, on the other extreme, when a patient is completely left lateral, the IVC is completely patent. This actually gives specific anatomic reason why lateral position is important in a pregnant trauma patient. If you look at the physiology of a pregnant trauma patient, there are several factors that need to be addressed. Very important, look at the minute ventilation. The minute ventilation is approximately 50% increased compared to baseline. Same thing with glomerular filtration rate, extremely high. And importantly, both blood volume and cardiac output are extremely elevated. Looking at this in the graphical form, you can see as you increase in gestational age, going to 40 weeks, you have a significant increase in your alveolar and minute ventilation, matched with an increase in your tidal volume. Again, looking at cardiac output also increases. However, your RBC volume increases, but not matched to the same degree that your total blood volume is. The classic laboratory findings, therefore, are an ABG where a patient is somewhat alkalotic with 7.48, somewhat hypocarbic with a PCO2 of 33, and a normal PaO2. Notice the hematocrit is 40%. That is a result of the having increased plasma volume, yet a fairly steady or only a slightly increased RBC volume. There is a slight leukocytosis, and the blood pressure for the most part remains normotensive. If you look at classes of shock as measured in a non-trauma patient, notice class 4 shock is associated with 40% blood loss. In this respect, your pulse rate will be increased, your blood pressure will be decreased, urine output was significantly decreased, and you'll have significant CNS symptoms. However, in a pregnant trauma patient, the first maternal physical signs actually come up after 40% blood loss. This is, as we mentioned before, because of the significant amount of blood volume in a pregnant patient. Importantly, fetal hypoperfusion occurs before maternal shock. If you look at the fetal considerations, uterine blood flow does not have autoregulation. Therefore, fetal blood flow compromise causes accelerations and decelerations in heart tones, and very specifically, trauma to the uterus can promote the release of arachidonic acid and specifically have early uterine contraction. Fetal survival decreases to less than 15% with signs of maternal shock. Therefore, maternal well-being is crucial to fetal viability. Trauma and pregnancy treatment is no different than any other patient in ATLS protocol. The ABCDs to the mother are paramount. Supplemental oxygen is of course helpful, And as mentioned, left lateral decubitus position, when possible, prevents maternal hypotension. Therefore, try this as maintaining best spine precaution. And of course, OB/GYN consultation is always important. Cervical examination, fetal heart tones, fetal ultrasound, and assessment of whether there's a rupture of chorioamniotic membranes is important. Remember the physiologic differences of pregnancy. Fetal maternal hemorrhage is an important consequence of trauma in pregnancy. Same with abruptio placentae and amniotic fluid emboli. The result of amniotic fluid entering the maternal circulation can cause massive anaphylactic response in hemodynamic collapse. However, this is rare, with only 1 in 80,000 pregnancies with isolated case reports happening from trauma. Fetal maternal hemorrhage, however, is something to consider. The transplacental hemorrhage of fetal blood into maternal circulation can happen in up to 10 to 30% of pregnant trauma. The major complication, of course, is RH sensitization. RH status of the mother is imperative. In this specific schematic, note when an RH negative mother has an RH positive baby in pregnancy, and there is trauma causing fetal maternal hemorrhage, the RH negative mother is sensitized and makes RH positive antibodies. Baby 1 delivers. However, if the RH mother is now pregnant again with an RH positive baby number 2, the RH antibodies that were sensitized and made from baby number 1 can cross the placenta and lyse the red blood cells of baby number 2. Therefore, antibodies from an RH sensitized mother with a future RH positive fetus can result in fetal RBC hemolysis and the disease process known as hydrops fetalis. RH immunoglobulin, specifically under the trade name Rogam, therapy is necessary for RH negative mothers. With Rogam treatment, the RH negative mother with an RH positive baby now will be blocked from forming RH antigens. Therefore, when baby 1 delivers, the RH negative mother remains antibody negative to RH. Therefore, if she's pregnant again with an RH positive baby, baby 2 delivers without consequence. The Kleihauer-Betke test is a way to evaluate whether there is actual fetal maternal hemorrhage. Only 1 fetal cell per 1,000 maternal cells corresponds to fetal maternal hemorrhage of only 5 cc's. Only 0.01 milliliters of fetal blood can RH sensitize a mother. 300 micrograms of Rogam for every 30 milliliters of fetal blood is the dose given within 72 hours. There are other ways to measure for maternal fetal hemorrhage, specifically flow cytometry. This is a picture, though dramatic, showing how significant hydrops fetalis can be in causing fetal compromise. Another complication is abruptio placentae. It's less than 5% in all trauma. However, it is associated with 50% fetal demise. Notice that the attached placentae can actually be disrupted and detached from the uterine wall, causing significant bleeding and eventual fetal circulatory disruption. Patients should undergo 24 hours of fetal monitoring, especially if gestational age is over 25 weeks. Tocolytics, not necessary since most uterine contractions are self-limited. Operative indications for mother are no different than any trauma patient. And perimortem cesarean section. Results are dismal, however there are isolated case reports. If necessary, radiation in terms of radiology for diagnosis is not contraindicated, especially if maternal well-being is in jeopardy. This is even more important if the gestational age is over 8 weeks. 5 to 10 rads carries virtually no fetal risk in morbidity, growth retardation, or congenital malformation. Just to give you an example, a chest X-ray only gives 0.05 rads. A CT head, again, 0.05 rads. A pelvic X-ray, 0.4 rads. And a CT abdomen of the pelvis can give up to 6 rads. Therefore, one can successfully give radiation in the right circumstance and have virtually no risk of fetal morbidity. In a study by Shaw, looking at pregnant patients with matched non-pregnant patients, notice the mortality is equivocal. Pneumonia is also equivocal. Total days and ICU days are also equivocal. Therefore, pregnant patients do not have a worse outcome. Of note, notice how rare it is to have fetal loss. Even under the one circumstance of having fetal loss, both the fetal heart rate and uterine activity were judged to be normal. Therefore, pregnant patients that are treated well and appropriately actually have excellent outcomes. And the National Trauma Database, again by the study from Akasi, Looking at over 77,000 women of childbearing age, and looking at those patients, approximately 1,200 that were pregnant, almost 1,100, over 1,100 survived the trauma. 17, however, did die. Those patients that survived, most of them were low risk, and those of them that had high risks had some loss of pregnancy. However, overall, the outcome for the mother and the fetus were excellent. Back to the teaching points, and in summation. Priority must be given to the mother. Save the mother, save the baby. Pregnant physiology is unique and should be appreciated. And finally, obstetrical consultation should be obtained promptly. Thank you.